We are so excited to welcome Dr. Lucille Carrier, who is going to be talking about Parkinson's and sleep, and everything that comes with it. I'm sure no one in the audience today has ever had a problem with sleep. Haha. So, Dr. Lucille Carrier is a staff health psychologist and director of the behavioral health program at the Cleveland Clinic Blue Ruvo Center for Brain Health. She earned her PhD from Auburn University and completed a health psychology fellowship at the Cleveland Clinic, specializing in multiple sclerosis. Her specialty, training, and interests include adjustment to chronic and neurodegenerative diseases, interdisciplinary care models, and behavioral sleep medicine. Dr. Carrier also holds the Angie Ruvo Endowed Caregiving Chair to support program development and research focused on family caregivers. Thank you so much for joining us today.
Yes, thank you all. I'm really glad to be here with you this morning. So, Brandy, from my screen, I'm going to share my slides.
Perfect.
Okay.
There we go.
How does that look on your end, Brandy?
Looks perfect. Full screen. You're great.
Okay, wonderful. All right. Well, again, I'm really pleased to be with y'all today. I'm going to talk to you about better sleep and Parkinson's and really focus on some practical tools for rest and hopefully renewal. So here's just kind of a broad overview of what I'm going to talk about with you today. As Brandy mentioned, I'm a clinical health psychologist. And so I really come at this from a psychotherapeutic, psychological lens. I do not prescribe medications, but in my behavioral sleep practice, we really focus a lot on the behaviors that can get in the way of good quality sleep. So you're going to see that theme throughout my presentation today as we kind of go through those things. What is it that's getting in the way when living with Parkinson's? And what are some strategies to hopefully start to overcome it and start a conversation or continue a conversation with your medical team? So first and foremost, let's start with this. I want you to think about what does a good night of sleep look like for you? In my behavioral sleep practice, I see a wide array of responses to this question. Sleep is such a kind of personalized experience, as well as how we think about our energy and our activity engagement during the day. So it can range from, well, Dr. Carrier, I really didn't wake up too much, to they may focus on, I got so much done today, or I didn't have to take as many naps. Or, you know what? My wife said I didn't really wake up too much last night, or I wasn't too active in my sleep. I wasn't having a conversation or moving around, or, those really odd dreams that I get from time to time didn't really have too much and they didn't wake me up. The takeaway here is again just how personalized this is. And I think that's really where we start to put sleep issues into context because they should be personalized, the recommendations, and how we work through them. So I want to take a minute just to talk a little bit about sleep changes just as we get older and the impact of Parkinson's. So probably no surprise to you that the majority of individuals living with Parkinson's experience sleep disruptions. In fact, it's 2 out of 3 people will note some disturbances in falling asleep, staying asleep, achieving quality or refreshing sleep, or feeling as though they don't have good energy during the day, or they're sleeping throughout the day. And that wasn't something that they typically did. When we step back and think about the impact that Parkinson's specifically has on sleep, it's kind of something that we're really kind of gathering more and more understanding of as research is taking off. But broadly speaking, we kind of think about it in these kind of bigger buckets, so to speak, and the impact that they have. First and foremost, we know that the pathology of Parkinson's disease itself can have a pretty big impact on sleep. And in fact, this can happen very early, often in those prodromal kind of stages of the disease. That is, before we even start to see the emergence of motor symptoms, we may be experiencing sleep issues. This may be in the form of, say, those very vivid nightmares or dreams or acting out. That can be kind of characteristic of early stage of Parkinson's. But specifically, we know that the disease will affect those sleep controlling regions deep in the brain. So a lot of that has kind of an organic nature to it. We also know, probably no surprise, that the symptoms consistent with Parkinson's can really get in the way of sleep. So we see this particularly as the disease progresses, where we're experiencing perhaps more burden from these diseases or from the symptoms, excuse me. So we may see the impact where motor symptoms are having an effect. We see challenges with rigidity, nocturia, that is getting up repeatedly during the night because you need to go to the bathroom, mood, anxiety symptoms, hallucinations. These can all affect sleep in various different ways, whether it's falling asleep or more often when we wake up, what causes the wake up, and then what extends the time in which we're awake. We also see where medications can have an impact. Certainly with Parkinson's, your medication regimen can be quite complex, and it can include a number of different medication classes, from the dopaminergic therapies to the agonists to medications for mood, anxiety, bladder, your thinking and cognition. And so, as you can imagine, the side effects from those medications may increase sleepiness when we don't want to see sleepiness, say in the middle of the day, or it may cause some alertness when we're trying to wind down and prepare for bedtime. And certainly, the more medications we see, the more chances for side effects and those interactions to take hold and affect our sleep in negative ways. Again, the kind of big piece that we want to see is that sleep disorders can occur because of the disease impact very early on. It's not something where it's later in the disease, I don't have to think about it. We know very early on individuals are experiencing sleep disruptions and meeting criteria for sleep disorders. And unfortunately, we can see where the impact of all of these kind of buckets can worsen over time, particularly if we're not catching it early and treating it. We also know that these symptoms, again, can affect individuals in such a way that we're seeing co-occurring sleep disorders. So while it's not so much the focus of my talk today, certainly with sleep disorders, we're seeing more and more in individuals living with Parkinson's that we would not see in their peers. Kind of healthy age-matched individuals. So again, I think it just really speaks to the complexity of sleep disturbances and sleep disorders that we see in those living with Parkinson's. Now, we also have to appreciate the role of aging on sleep. So often, individuals will present to my clinic, will be talking about sleep issues, and they may say, I think it's just because I'm getting older. And so we'll talk about that because there are changes that we see with our sleep architecture and our patterns over time. So beginning in our 20s, actually, and extending for several decades, typically into our early 60s, we do see these changes. Specifically, we see where we start to sleep a little less, so that like total sleep time just slowly starts to erode by just a few minutes with each decade. We also see where, the amount of time that it takes to fall asleep can also change too, such that it maybe takes a little bit more time. We also see an increase in nighttime awakenings. Certainly, that kind of sleep fragmentation that we often think of, where we're waking up multiple times per night for variable amounts of time, can be um, really kind of a big impact on overall sleep quality. And then we also see where there's a bit of an advancement in our sleep schedules. That is, you may find that, your bedtime starts to kind of get earlier and earlier over time. Now, we also know that our melatonin, which is kind of a natural chronobiotic, we think of it as in our body, also decreases with time, which helps with sleep timing and initiation of sleep. as well as changes in our sex hormones. So testosterone and other female hormones are also going to start changing. So those are all going to affect our sleep and our experience of quality sleep over time. The big takeaway here, though, is that age alone can't explain where we have more sleep disruptions over time. Typically, when we look at it and we kind of parse out these factors, it's really more medical conditions and the medications in which we're using to treat those conditions that have the bigger effect than it is aging per se. So when we put this all together, right, we really try to think about that experience of sleep and we break it down in terms of, well, how much time am I sleeping? The quantity of my sleep. And we also want to step back and look at the quality of sleep. And more often, it's that quality of sleep that people talk about. While we generally think we want to get that 7 to 8 hours of sleep, right? That number kind of sticks with us. It's where most of us probably feel are refreshed. That's not the case for everybody. People have varying different sleep needs and circumstances. So really where we focus from a treatment perspective is really thinking about how can we help you achieve that quality of sleep because that's really where we're hoping to see that translation into improvements in day-to-day functioning and overall life, particularly when we're living with a chronic neurological disease. So let's talk a little bit about what is it that gets in the way of sleep for you? As we've talked about and kind of set the stage with the role that Parkinson's can play, also too, as we're getting older, those age-related factors. We also do want to recognize there's other things here, right? So when we think about, your physical symptoms and discomfort, this is huge. It's hard to fall asleep when we're not feeling well or we're in pain or we're really stiff. There may be tremors at play. That's going to get in the way. We also, too, want to recognize other medical conditions. So, for instance, if we've got some urinary conditions, diabetes is a big one that could be at play, chronic pain conditions. Also, too, we're starting to look at the impact of depression, anxiety, and what those can do for sleep, particularly with falling asleep, staying asleep. Sleep disorders. This is huge, right? These standalone disorders that really can have a big impact on quality of sleep. So, this is where we're thinking about, say, REM sleep behavior disorder, which you may have heard of, that has the dream reenactment and the vivid dreaming that goes along with it. There could be hallucinations, restless leg syndrome, just that kind of incessant need to move your legs around because you just can't get them kind of quiet. They're uncomfortable feeling. If there's any type of breathing related sleep disorders, those can all affect quality of sleep and daytime functioning. We also have to look at your sleeping environment. We'll talk a little bit about this later on, but certainly temperature and light and the presence of a bed partner can all kind of play a role in this in terms of, again, how we're sleeping through the night. And of course, these lifestyle factors. As a clinical psychologist, this is where I lean in a lot, is kind of understanding your habits and routines around sleep promotion. So, what are we doing in the bed besides sleeping? That is, are we watching TV or on our other electronic devices? Of course, eating or drinking before bed can affect our other bodily symptoms. Are we having really big conversations and making big decisions when we're in the bed with our partners? Those things can kind of weigh on us and affect, unfortunately, our sleep. Now, we also want to think about what's happening in the daytime. So when I see my patients in clinic, they're often surprised that we're talking a lot about what's happening during the day. They're seeing me thinking we're just going to talk about what happens at night. But our daytime activities have a significant impact on this. So this is really where we're really focused on what are your routines? What are you doing in those hours leading up to bedtime? What does your bedtime routine look like? How are you winding down for the night? Also, too, what are you doing during the day in terms of activities? I know later today, one of the speakers is going to talk about the power of exercise and how huge that is when living with Parkinson's. But What does that look like? Do you have activities that are meaningful and bringing you joy that you're also engaging in? Or do you feel like you sit most of the day and maybe watch TV and have a bit more kind of sedentary activities? Well, that's going to affect us when we think about nighttime, right? We're not getting that activity, kind of moving our body. There's not a lot of delineation between daytime, nighttime activities. All of those things are important for our brain to recognize it is ready for sleep and how do we start to prepare it. Also, too, we have to be careful that as we get older, we tend to have less light and sunlight exposure. And this can really be kind of a powerful trigger for our internal sleep clock and our keeping our circadian rhythms on play. This can also be something to think about, too, as we're approaching the winter months and less sunlight. But this can also have an effect on the timing of our sleep and our sense of alertness. And then, of course, our mood. This is a really big piece, right? So much that we think about when living with Parkinson's and the role that depression and anxiety can play, both of which, have sleep disruptions as part of depression, as part of anxiety. And so this is something that can absolutely affect our sleep at night. So here's really where I want to kind of jump in and think about, all right, what can we do to optimize our physical health in that sleep environment to really kind of set ourselves up for success in our sleep? So, first and foremost, when we are starting to notice that we're having sleep issues or they've been just kind of there for quite some time, really what we want to do is kind of take a step back as a medical team, as a provider, and we really want to think about what do we think is getting in the way of sleep? What are the unique aspects of your sleep difficulties? So, this is where a clinician is going to ask, well, tell me about the nature of your sleep patterns. What is it that's most bothersome to you, right? Are you having problems falling asleep? Or more often than not, in Parkinson's, it's going to be trouble staying asleep. You're going to have that fragmentation. So this is really where we want to look at, is Parkinson's symptoms, are they playing a role in any way? The motor, non-motor, because this may be where we need to make some adjustments to, your dopaminergic therapy and other medication regimens, right? Particularly if you're having some wearing off before bed, you're having some tremors, they're getting in the way of sleep. That's huge, right? And that is where your neurology provider will play a big role and kind of trying to determine, are there some medication adjustments we can make? Certainly, those psychiatric symptoms I mentioned, mood, anxiety, are going to be key that we also want to ensure that we're managing. And then, of course, we look at these other non-medical conditions that are unrelated to Parkinson's, but also to playing a role. So if you feel like it's just, I'm getting up repeatedly throughout the night to go to the bathroom, well, that's really where you and your provider should have a conversation of, is this something that they can help manage? Does this require perhaps a referral to specialty providers where they can play a role too? This is where sleep medicine can really play a big role, and of course other medical specialties, but it's really about understanding, are there medical symptoms driving some of these challenges with sleep? We also want to take a look at any breathing related sleep disorders that could be at play. So, sleep apnea is certainly something that we want to look at. We know that the connection with untreated sleep apnea, right, where you're having periods during the night where you're not breathing, oftentimes because there's some type of obstruction or anatomical feature that's getting in the way. So, you're having these hypoxic episodes throughout the night. And so, what we know, though, from the research is pretty clear in that individuals living with Parkinson's can experience a worsening in their motor function as well as their cognition. And this can be pretty significant, particularly as we know that there's vulnerabilities to our cognition when living with Parkinson's. And so, we certainly don't want to add these extra burdens related to, a decline in your short-term memory or your processing speed or your decision making. And so this is really where we kind of look to see, all right, what can we do to kind of better optimize that? Because I do have a fair amount of individuals that will present to my clinic, and there is a sleep apnea diagnosis, and unfortunately, either it hasn't been diagnosed, and so we facilitate referral to those specialists to diagnose that, or adhering to treatments has been really difficult. So we certainly recognize the high rate of challenges in adjusting to, say, PAP therapy, where you have the mask that you wear at night, or maybe there's a mouth guard, for instance, that you could be wearing, but they can be difficult, and a lot of people really struggle with that. So this is really where we're looking at what can we do to kind of prioritize that. What kind of subspecialized support might you need? Do we need to kind of give a little bit more creativity to how we can incorporate that into our nighttime routine, help you feel more comfortable with it? Is it, say, a new mask, for example? Is it getting your support partner in place to kind of help with this? But research has showed that we can make some improvements here, and behavioral interventions can be really helpful with increasing usage of these different therapies during the night. So this is really where I encourage you to talk to your provider and see if you can get some ideas or connections to different specialties that can help with this. Certainly, there are certain types of mental health providers that have specialty in this, or even sleep specialists that can give some guidance as to kind of how we start to help kind of improving this. I work in a brain health center, and so much of what I do is how can we help protect your brain? We've got vulnerabilities because of Parkinson's. And if there's one thing we know about these breathing related sleep disorders is that they can contribute to an acceleration in cognitive decline. And that's the last thing we want. So what can we do to kind of help you feel more supported with treatments here? The other piece I want to talk with you about is how we create a safe sleeping environment. This can be something where we really kind of look to see, is there REM sleep behavior disorder present? So with REM sleep behavior disorder, what we're seeing is that during the night while you're sleeping, when you enter REM sleep, which is kind of at the end of your sleep cycle, typically in the absence of this disorder, we're relatively paralyzed. Our brain just kind of shuts down our skeletal muscles and we're nice and quiet while we're actively dreaming. Our brain is very active. With REM sleep behavior disorder, that's kind of flipped off. So this is really where you see that very active movement and engagement and kind of living out the dreams in real life. For most people, they are completely unaware because you are sleeping. But what your bed partners will report, though, is a variety of different, sometimes unsettling things. You may be yelling and screaming and cursing. There may be even laughing. You could be having full conversations, muttering certain things. There's a lot of kind of upper body extremity movement. So you may be kicking or kind of hitting or punching. And unfortunately, this can result in injury. So whether you're falling out of the bed, you're hitting things around you, or in more extreme cases, if you're hitting your partner, all inadvertently, you're very unaware of it. But this can be really disconcerting for partners, and particularly for you as you're finding out about it the next morning. And so, some things that we really want to think about, it really comes down to kind of setting up a really safe bedroom environment. So here's where we're thinking about, placement of the mattress on the floor, for example, if you're falling out frequently. This may be where we need to move nightstands and lamps from kind of proximity of the bed. Sometimes people will add padding to the bed frame or to the floor around them, particularly if there's a lot of arm and leg movements that's happening. Sometimes they may find that, you may sleep in a sleeping bag to kind of keep things a little bit more contained, but this is really where we try to get creative. It's really challenging to predict how often you may experience these episodes once they have started, or even kind of the prognosis of it. It varies so much within individuals and across individuals when they're living with REM sleep behavior disorder. But oftentimes, when I'm working with individuals who have been referred to my clinic, for example, um, they're relatively unaware of this unless there have been injuries, for example, or they're waking up and those really vivid dreams are with them, they're bothersome. So we may talk through a plan of kind of how to kind of calm the mind, calm those emotions, the body to get you back to sleep. But more often, what we're focusing on is that shared sleeping plan with their bed partner. It's upsetting, as I mentioned, for partners to see this, to not know what to do. And of course, if they're experiencing injuries, this is something we really need to kind of talk about and escalate. So, we're going to talk about that in just a minute as to kind of how do we navigate that sleeping plan. All right, so let's think through also, how do we look at our routine and our environment? So, some really big takeaways here that I want you to think about is how do we maintain consistency in our bedtime and our wake time? This is huge. This is really where we're able to promote good sleep regulation and getting our internal body clock such that it's kind of nice and regulated. This is important. And so while we may have some trouble controlling our own bedtime, because maybe we're not sleepy at all the times and we don't want to force sleep, maintaining a consistent wake up time is really critical. And so that's the one we have the most control over because we can set alarms and ensure that we're waking up at those consistent times to keep our schedules in sync with that kind of around us and nice and healthy. We may find, though, that we struggle with sleepiness during the day. And so this is really where we look at kind of some strategic napping. Napping sometimes can get, a bad reputation when you start talking to folks about, behavioral sleep treatments and kind of needing to eliminate napping, particularly if it's excessive. But oftentimes, this is really where we need to make some adjustments to behavioral sleep treatment, particularly when living with Parkinson's, because again, the sleepiness needs to be something where we, make some changes to. So maybe we set some particular times during the day where we have those brief naps kind of incorporated into one's routine, just really as a way to compensate for that sleepiness. We also, too, want to make sure we have a really strong association between the bed and sleeping. So, this is really where we're looking to take out all of those wakeful activities that may be happening in the bed. This can often be the case when we may use our beds as an extension of our living rooms or family rooms. So, we're relaxing in there, we're watching TV, maybe we're on tablets or reading, but unfortunately, it's reducing that association between the bed and sleep. So you put all those things away, you turn the lamp off, you're kind of rolling over, and you start to have maybe a little trouble sleeping or falling asleep. The brain is having trouble kind of transitioning into sleep. So this is really where we want to remove those things from the bed. We want to really ensure that we're going to bed when we're feeling sleepy. So this is key. We're looking for those sleepiness cues. All of these things, though, can kind of help with setting that routine for better sleep quality. So back to that shared sleeping plan. So this is really where we want to think about how do we have a conversation about this with our partners when we're having these sleep difficulties. So it may be that dream reenactment where you're really active during the night, or maybe you're struggling with insomnia or bathroom trips and you're just up and down for what seems like the entirety of the night. What I want you to think about is how do you have the conversation? Because so often what happens is we may not, partners and those living with Parkinson's oftentimes make the changes, but they don't have the conversation. So I wanted to give you some things just to kind of think about, maybe serve as just some conversation starters. But first and foremost, we need to think about safety. So again, if we have dream reenactment that's pretty significant and frequent, this is really where we want to obviously reduce, or if we can completely eliminate risk to bed partners if they are kind of experiencing this during the night. So there's various ways in which to try this. You can put kind of pillows in between depending on the size of your bed. Sometimes people will elect for larger beds just to allow people to spread out more, put more of those pillow barriers in place. Sometimes people will put two twin beds in the room, and depending on preference, they may be closer or further apart. This is really where we get creative. Some couples may elect to sleep in separate rooms, so that's also too a consideration. But it's really about the collaboration on what's going to work best for us as a couple. There are so many different ways. There's no specific or one size fits all approach to this in terms of how we navigate these sleep issues within partnerships. Again, we really want to find ways that we can foster that sense of intimacy and closeness with our partners and prioritize each individual partner's or kind of individual's sleep needs and their sleep quality. So maybe this is where we have to plan our intimacy, whether it's erotic or non-erotic forms of intimacy. Can we have a shared wind down period with one another? Where maybe we get into the bed, we have our intimate time together, and then maybe we part ways, such that the other person then is moving to the other room, or you have those barriers in place. But that's a big piece to this. And again, it's just how do we prioritize sleeping quality? Because we know there's more and more research that's actually emerging that we know about care partners, Parkinson's care partners, and the impact that care partnering can have on their sleep. And how do we help prioritize that such that they can get that restful sleep and really be the most present and kind of engaged care partner and feel their best while they're kind of, navigating a lot of different roles. So just know sleeping arrangements are likely going to change over time, perhaps as a function of the disease, the symptoms, and just the level of care or support that your partner may be playing. But don't be afraid to have the conversations. All right, so now I want to switch gears just a little bit and talk about some ways in which we can calm that active mind that so many of us may have at night. So, whether this is kind of present when you are trying to fall asleep, or maybe it's I'm getting up and I'm using the bathroom, or I heard something, or I'm needing to kind of just turn over in the bed, that mind just starts rolling and it just doesn't turn off at night. And so, it can present in a lot of different ways. It's one particular thing you've got on your mind, or just kind of everything's coming at you. But it's hard to control those worries and calm them enough to fall back asleep. And so, what I often like to remind my patients when, they're telling me about these challenges that are coming up or things that are just kind of gnawing on them, they're trying to think through solutions. They're trying to be kind of proactive about it. But unfortunately, I don't know about you all, but my tired brain at 2 or 3 in the morning just isn't really that great of a problem solver. And so this is really where I encourage not to engage in that problem solving because, if anything, we're kind of stirring up what's going on, that activity in our mind. And that's going to be counter to wanting to kind of slow down and prepare ourselves to get back to sleep. So just some things to think about, right? Like, is this a sign of, the anxiety or depression maybe that has gone untreated or that has kind of maybe flaring up again that we need to address? Is this acute? Is this something that's been on my mind? To what extent am I thinking about things from the past? Is this, perhaps just something that I'm running through my to-do list for tomorrow? And I just want to run through it enough so I don't forget it, right? Those are important. And I think from a psychologist and mental health provider perspective, I'm looking for those gems because then I'm going to personalize such an approach so that we can get a handle on that and it's not interfering with sleep at night. So, one way we kind of start to do that is really creating what we call a buffer zone before bed. This is really trying to signal to your brain it is time to wind down. We have to kind of shut down. So, this is really where we're kind of disconnecting from our electronics. We're disconnecting from all those kind of activities and chores that may be happening in the evening time. And we're really trying to build in a relaxing period. So, this isn't necessarily I'm brushing my teeth and putting my pajamas on. Hopefully, we've done that already. This is really kind of a quiet time. So, this could be where we're doing something a bit more relaxing, maybe even engaging in some relaxation principles or practices. But generally speaking, people vary a little bit in terms of how much time they need in that buffer zone. could be 20 minutes, could be an hour for you, particularly if you're working into the evening or you're watching a really kind of emotionally charged show or movie, or you took the dog out. Kind of think about those things, right? And how that may kind of prolong that ability to fall asleep. Sometimes people find it's really helpful if we can write down where those worries are going. So I call this a brain dump. Now, this is something we don't necessarily want to do right before we crawl into bed because what's going to happen? We're going to be thinking about the things we just wrote down. So, this is something we want to do well before that buffer zone. But it could be this is where I'm writing down what do I need to do tomorrow, right? So maybe I'm having a little bit more difficulty with remembering and organizing, and I'm trying to stay on top of my calendar. That's great. We want to use those memory tools. So let's write down what we need to do tomorrow. What's on that list? Are there things that are bothering you that you need to kind of give some thought to, some stressors? The goal, though, is we write them down and then we make a plan and kind of I don't know, almost like an agreement with ourselves. We're going to do this tomorrow when I'm more fresh and I'm well rested. That's the ideal time to do it. There's actually been a little bit of research on this that if we can do this for those future oriented tasks, it does help with decreasing amount of time to fall asleep at night. So there is some research behind this. And of course, we need to think about what's happening in our body, right? We're thinking about emotionally charged things and our minds are active, but so too are our bodies, right? Maybe we're getting a little bit more tension, or our heart's racing a little more, we're breathing a little faster. So, what can we do to kind of soothe the body when these thoughts are kind of racing through our mind? So, this is really where direct physiological relaxation practices can be really helpful, particularly during those buffer zones, right? Before bed or as we're waking during the night. And we need to do this. So thinking about 15, 20 minutes even, can we do some diaphragmatic breathing, guided imagery? There are so many different types of relaxation principles and practices. It's really about finding what works for you because it's not quite a one size fits all. I often find we have ones that we kind of connect with more than others. And how can we kind of incorporate those in? We also want to think, can we do a little bit of stretching? Would there be some benefit to that? I think this is a really great plug for your rehabilitation providers and some practices maybe that they've taught you or you're actively in physiotherapy, physical therapy. Talk to them, right? How can we, again, maybe relieve a little bit of tension that's in your body? And then, of course, there's other ways that we can help kind of quiet that mind, whether it may be with some reading, music, and of course, some gratitude journaling, kind of in the night on a positive note with some good emotions can be really helpful too. There are a multitude of different relaxation audio kind of programs, apps, clips, all sorts of things that you can find. So I wanted to highlight one here that the Cleveland Clinic provides that has some really nice and I like brief, right? Less than 10 minutes. That you can kind of listen to this as you're preparing for bed to again really start to kind of calm and slow the mind and the body so that we can be in a really good state of mind as we prepare for bedtime. So perhaps as you're thinking about this and you're listening to the presentation this hour, maybe this is starting to kind of, trigger for you. Maybe there are some things I can do, and I am worried about kind of how my sleep patterns have been. And so this is really where we have you start tracking it. Because what we know, particularly from an insomnia perspective, which is one of the most common sleep disorders that those living with Parkinson's experience, is that it can vary so much night to night. And you may not see your provider with great frequency. So when you finally do see them, they say, "Well, how's your sleep?" And you may have a blank, or you're saying it's awful, it's really bad, and it's hard to kind of pull in those specifics that can be really helpful from a diagnostic standpoint and looking at treatments. So this is really where we can kind of want you, coming from a medical perspective, to kind of start tracking some of these things, right? The pieces that do bother you. What is it about your sleep routine, right? When are you getting into the bed? Is it problems with the falling asleep or Probably more so, how many times are you waking up at night? How long are you awake for? What do you think's waking you up? Those little descriptive pieces, again, can be really helpful. If it is in preparation for a medical visit, perhaps you can log it for a week or two beforehand. Maybe this is where, your support partner can be really helpful in helping you jog things down. I often really enjoy when care partners are part of my visits with patients because we can really kind of fill in the details. There's a lot of things they observe, particularly when their partner is sleeping. That's really helpful from a diagnostic standpoint. For me to kind of understand some of those nuances. And there's lots of different ways you can do this. There's really great apps that are out there. There's wearable devices. Again, I think it's just kind of starting the process, gathering some of that data so that you have that when you see the provider and can really make the most out of those visits. One app you might want to think about that we have through our institution, it's called Sleep by Cleveland Clinic. And this is where you can track those sleep habits during the night. You can get a sleep score and some individualized recommendations to help improve overall sleep quality. So this is something I really encourage you to think about. It's one of many that you can consider. But those can oftentimes be helpful when the paper pencil copies can be a little challenging sometimes to keep up with. But really, the big piece here is starting or continuing a conversation about your sleep to your providers. This may not be something that is routinely asked during your medical visits. So, this is really where I really want you bringing this up, being proactive, talking about poor quality of sleep, sleeping too much during the day. What is it that's bothersome to you? What is it getting in the way of in terms of life and activities that are important to you? Are you noticing any relationship to your Parkinson's symptoms? Bring that forward. That's really helpful to know. Are there other aspects to medical conditions or health behaviors in general that you think could be contributing? Those are all important pieces to mention so that you can maybe hopefully start a conversation that leads to assessment and then, of course, treatment. Because again, as I mentioned at the beginning, if there's one thing we know about sleep disorders and Parkinson's, is that so often they're underreported, they're underdiagnosed, and they're undertreated. So start those conversations. Perhaps you don't have a visit upcoming anytime soon. Send a message in to your provider. Can you talk to the nurse at the clinic or whomever to, again, bring forth those challenges and what you're going through? I wanted to mention here as well that there is a strong role for behavioral sleep treatments. Not so much the focus of our talk today, but this is really what I would do as a behavioral health specialist in the sleep space. So there are evidence-based treatments with decades of research that we can utilize that are relatively short-term and can really show some improvements, particularly in the space of insomnia, where we're having difficulty falling and staying asleep, and nightmares even. And so these can be really effective in terms of just, again, improving those symptoms and helping you feel better during the day. The premise for these types of treatments is that we really see unhealthy sleep habits. Maybe I'm spending more time in the bed to make up for lost sleep. I'm going, getting in too early or I'm sleeping in later. These kinds of habits, while well meaning, can work against what we know from a sleep science perspective. And so, what we do is we unlearn those behaviors with structured behavioral and cognitive approaches. It's important to note that these behavioral sleep treatments aren't the same as, say, sleep hygiene, which are really great preventative strategies, right? Just like you go see the dentist and you see the dental hygienist, what we want to do is floss and brush our teeth. Same thing too from a sleep hygiene perspective, right? We don't want to exercise right before bed or, consume a lot of alcohol before bed because those types of things can get in the way. Unfortunately, when we have insomnia that's already present, sleep hygiene changes really aren't going to be enough to move the needle to improve the sleep disorder. So this is really where we need to move to an intervention perspective, and that's what the behavioral sleep treatments can provide you. I've talked a lot today about what I do as a psychologist and as part of the mental health field. But I also recognize that my colleagues, who you may be seeing from the rehabilitation space, from nursing, can all play a role in terms of helping you with your sleep. So maybe there's access challenges to seeing a specialized sleep provider. I want you to see here, while this list is not exclusive or exhaustive, but that each of these individuals that may be part of your Parkinson's care team can play a role in helping to address these sleep issues. So, from a physiotherapist perspective, what you can see is, are we getting good exercise and these strength-based routines and just active movements during the day in safe ways that can ultimately help us with improved sleep at night? Looking at safe bedroom environments, occupational therapists, same thing. What I love about OTs is their focus on activity schedules and routines, setting up safe and supportive sleep environments. They can be really quite helpful in. Of course, our nursing team, we could not do this without them. They play also a huge role too, right? Helping you with more complex medication schedules that you may be taking during the night, helping you kind of optimize that schedule, the safe bedrooms. You also may need some type of schedule with your bladder, for example. This is where the nurses can be really, really quite helpful. And of course, speech language therapists, particularly if we're having some challenges with respiratory or breath control, they can be helpful. Also, too, they have a really big focus on helping with cognitive strategies. And so, this is where they can help support those sleep routines and behaviors that we're putting into place by giving some ways to kind of help with compensatory memory strategies, for example. But again, the takeaway here is that it really does require a team. And I am one of many who can help with better addressing these sleep issues and helping to improve, hopefully, that quality of sleep for you and your partner. So, just in summary, quality sleep is so vital when we're living with Parkinson's and not. But certainly, when we see these disruptions when we're living with Parkinson's, the consequences can really be quite significant and can accumulate over time. So, those sleep changes, we want you to see them, notice them, start a conversation with your provider. Comprehensive management is really critical. Certainly, these sleep disruptions can be quite complex. We may have multiple sleep disorders that are present, and each of those are going to really require an individualized approach to how we better navigate that and improve your sleep quality. There are a lot of different behavioral strategies that can really be quite effective in addressing some of these sleep concerns. And so it's something where hopefully you can get connected with somebody that can help provide that care, so that you're not living with these challenges and feeling as though there's nothing we can do about it. I want to give you a sense of hope that your team, your Parkinson's team, whomever that might include, can really play an important role in addressing those sleep issues.
Are we ready for questions?
Yes.
Yay! So there's a few. So we'll try and get through them as fast as we can so everybody can have lunch. How does one best deal with excessive daytime sleepiness?
That can be quite a challenge, and one that is pretty common when living with Parkinson's. So, a couple things that I would think about with excessive daytime sleepiness is that we really want a thorough evaluation, because that excessive daytime sleepiness may be due to the Parkinson's disease itself, or it could also be due to maybe an underlying sleep disorder that we haven't diagnosed and we're not treating. It could be some of those behavioral factors. We need to look at maybe optimizing one's sleep routine. We may need to look at just overall activities during the day. Do we have enough activities and stimulation during the day that are important too? Because maybe, as my last presenter, I overheard the last part of his, maybe there's a little bit of apathy or depression or anxiety that's getting in the way that could be contributing from that withdrawal kind of from life. I'm sedentary, sitting still, and I get sleepy. There also could be a role for medications. Sometimes there are wakeful promoting medications that providers can consider too on an individual basis. So I think it's just kind of taking a big picture look and ensuring that the factors that are there that we can make some changes to, we're doing that. And then, of course, strategic napping, as I talked about. Think can
I
be.
like me a strategic nap. Is there any kind of set or parameters for how many hours of deep light and REM sleep one should be getting? And does that amount change as we get older or as PD progresses?
Yeah, so generally speaking, we do see where individuals will sleep less over time. And we tend to see where older adults will spend just a bit more time in those lighter stages of sleep, which means we're going to be more susceptible to waking up to environmental things, right? We're listening to bladder cues and such. So that can lead to, I think, some unrefreshing sleep that we'll see over time. And then, of course, with Parkinson's, again, just maintaining continuity of sleep is really difficult. From really an organic standpoint, is how a lot of times we're looking at it. What we often get concerned about is, right, we may be waking up, and then what are we doing when we're waking up? So that's really where I come in to kind of ensure that we're not doing things that are prolonging that. I'm fortunate to work in a center where my movement disorder specialists are just a couple doors down from me. So this is really where we work from a collaborative standpoint of here's the things I'm doing from a behavioral standpoint, but I'm also looking for some of those medical and motor symptoms that I'm working with the doctor that perhaps over time need to be addressed. They need to make some changes too. So it does change, and I think it's something that we want to be mindful of.
So gonna bunch a couple up here together if that's
Yeah.
all right. So they're all about the strategic napping. So uh, I've got one that says like, should I let my loved one with PD nap during the day or try and keep them more active and awake? This is in conjunction with, can you elaborate on briefly on strategic
Yeah.
napping and what's a brief
Yeah.
nap?
Oh, great question. I'll have to add another slide next time. So with strategic napping, what we really are getting at is that it's got a planned element to it. So it's not this kind of free running schedule throughout the day where we're just kind of napping on and off all day. That we don't want to do because what happens there, right? You're withdrawing from life. You may be missing medication doses. You're not getting your exercise in. You may be missing meals. It just compounds. So that's the last thing we want to see. So with strategic napping, more often what I like to do is kind of look at your sleep schedule and then think about during the day. For instance, I might say, well, when do you find that you get the most sleepiest? Is it after your dopaminergic dose, if it's an agonist, or if it's your regular carbidopa levodopa? Like when are you feeling your sleepiest, right? Is it after activities? Is it in the afternoon? Are you in the morning? And so I like to kind of use that as a gauge to know when we can add in a nap, maybe two. Typically, we like them brief, so that's 30 minutes or less. So usually with naps, just physiologically speaking, we tend to nap best if it's time 6 to 7 hours after we wake up in the morning. So thinking about that, that's something where physiologically we just kind of have the best match for our body's just a little bit more primed for a nap at that point. So that's something to think about. I think when we are looking at Parkinson's and cognitive changes, and we're starting to see where individuals have entered into dementia, I think one of the challenges is that we're just kind of seeing a global slowing. And so we may see more napping throughout the day. So I think in those individuals, what's really helpful for care partners is thinking about activities, um, short activities, but things that can help individuals be stimulated. Maybe it's going outside, getting a little bit of sunshine, a little bit of light movement that's safe. Those can be helpful too with combating sleepiness. But I think it's just keeping the conversation with your provider if you're noticing more and more sleepiness. That's something we would need to give some further attention to.
Just two more and then we'll get everybody out for lunch. Is talking in your sleep a PD related sleep disruption? And what happens if that's been going on before your diagnosis of PD?
Yeah, great question. And more often than not, vocalizations, conversations that happen while the person is fully asleep may be part of dream reenactment, which is really a larger sleep disorder that we call REM sleep behavior disorder. That more often than not is a kind of a biomarker, so to speak, for later development of Parkinson's disease and a few other types of neurodegenerative diseases. And so, is it concerning? I think we just want to look at, is it waking you up? Sometimes people sleep completely through it and they are unaware. Other times there may be the bed partner interference, or if it's waking you up and you're not able to go back to sleep and it's prolonging sleep, or the wakefulness, that's something we need to look at.
So the last one, same kind of track about REM sleep behavior disorder. Um, Two parts to it.
Yeah.
When one is in REM sleep behavior disorder, the person with Parkinson's saying like they don't really remember it, but their wife does. Are they actually getting sleep during that time? And then
Mhm.
B, to that, does it worsen over time?
Great questions. Yeah, they're actually sleeping. And does it worsen over time? I think this is what's really challenging to predict in terms of, individuals may have multiple episodes per night because we'll cycle every 90 minutes in a sleep cycle. So you're usually in REM for about 10 minutes, but there can be other medications and medical conditions that can shorten or lengthen that. So you may see it at varying times, but you can have it multiple times a night and then go weeks and months and not have it. Or it could be 3 times a year. I think that's what's really difficult for us to predict. I think we just think about safety more often than not. Bed partners will ask, "Do I wake them up?" I think if they're really moving and you're concerned that they may hurt themselves or you, I think that would be an appropriate time to think about how to approach them in a safe way to wake them up. I think if it's some talking and it's not bothersome to you, you could leave it. But again, this is really where I come back to that shared conversation that's happening more and more. Care partners, we've got to think about your quality of sleep as well, so you can really be your best self.
Awesome. Well, thank you so much for joining us today and for taking the
Yeah.
time. There's great comments, a thoughtful and a excellent, comprehensive, non-judgmental presentation. So truly, thank you so much for joining us today.
Oh, wonderful.